Welcome, my digital pathology trailblazers. A couple of updates. So let's start with a few updates. Update number one is the next conference. The next conference is SITC, Society of Immune Therapy and Cancer, and that is gonna be in near DC National Harbor, 7th and 8th of November, which is Friday and Saturday. And the important thing is Saturday, because I'm going there with sponsors, with Hamamatsu and with BioCare. Our booth is going to be 415.
Learn about the newest digital pathology trends in science and industry, meet the most interesting people in the niche, and gain insights relevant to your own projects. Here is where pathology meets computer science. You are listening to the Digital Pathology Podcast with your host, Dr. Alexandra Zhurov.
Okay, so we have From Spatial Biology to Clinical Utility. It's a talk by Carlo Bifulco, who is very active in this spatial biology space, and he was working with markers, with lung cancer markers. So I'm super interested about this one, because usually the notion or the idea is, okay, I have immunofluorescence, and this is more like for research, and then if you want to take it into clinic, you'd rather translate it into bright field, right? Because it's less cumbersome. But here they're going to be talking about from spatial biology to clinical utility. I'm going to be there. Several people are already saying that they're going to be there. So I hope you're going to be there too. If you're in SITC, leave me a comment that you're going to be there, and definitely come and visit booth number 415. I'm going to be there with Hamamatsu and BioCare. So that is update number one. I'm super happy about this because I can just drive. I love the conferences where I can just drive and I don't have to fly, because I had to fly to ACVP, American College of Veterinary Pathology annual meeting, where I gave a talk on black box, how we can get from AI, like from the black box to AI reliability and utility. And I'm going to record this talk for you and post it on LinkedIn. The only thing I wanted to tell you about that conference, that so it's for veterinary pathologists, but we are so not lagging behind. Amazing talks about research applications. My talk about more like tool deployment, regulatory environment, reliability and liability of AI in this space, and also everything in between. A lot about domain shift, and there is a paper that we're going to be discussing that covers domain shift. And without further ado, let's go and cover the first paper of ours, multi-institutional validation of AI models for classifying urothelial neoplasms in digital pathology. And what do we have here? Well, the deep learning approaches for classifying normal, non-invasive and invasive urothelial neoplasms through digital histopathology images. And they say, well, AI is almost everywhere, but where is it in bladder cancer? Let's do it for bladder cancer. So they developed convolutional neural networks and transformer-based models. So important, like, I don't know if it's a trend. I guess it's not a trend, but something. So now, like, the big new thing are the transformers, right? And when I started that, every time I would learn about a new modality, so first we started with, and that was also something I covered in my ACVP talk, that we started with rule-based approaches, right? So we knew like what intensity a cell had, and we had to define it. And then, like, depending where we would put the threshold, we would lose cells or have too many cells, whatever. But we knew what was happening, but it wasn't fantastic. And then convolutional neural networks came, and I was like, oh, now we can give examples, now we can throw this other thing away. And then I look at the results and I'm like, could we combine? And now I see the same happening. Well, it's not rocket science, probably. I just always get like over enthusiastic about the new thing and forget about the old thing. But here we have the CNNs and we have transformers, and they were trained on a lot of images, 12,500 whole slide images. So I don't know if you remember like the beginnings of this space, you would have 100 and you would be like, oh my goodness, that's huge data set. And now we have 12,500. And this is amazing. Although for training, you don't always need so much, especially if you do like cell-based stuff where you have a lot of cells in one image, you can still get away with, just 20 or something, right? So, but they had a lot, over 12,000, 5 institutions, and then they included stain normalization and patch extraction techniques and did cross-validation against expert annotated labels. And they had different models, and the one that was the best was efficient net B6. And when I looked at the metrics, okay, accuracy 0.913. I'm like not surprised when I see accuracy so high in these papers. Sensitivity over 0.9, specificity over 0.9. I kind of like, these are metrics that you have to like know what they are and know what it means, because you can have like super high accuracy, but you claim everything is negative and the prevalence of the disease is super low, and you're still going to be super accurate. But when I looked at this F1 score of 0.9, I'm like, is that really so good? So it was funny because at the ACVP, and if you're not familiar with these metrics, don't feel bad, because I have to relearn them every time. But these F1 is one of them that comes like returns over and over again. So I kind of like know my numbers. And at ACVP, we're talking about data sets and about measuring all these metrics. And one speaker, Christoph Vetram, who was also the chair, one of the chairs of the of my session, the AI session, gave this question at the beginning. F1 score of 0.7, is it good or bad? And if you don't do it on a regular basis, you have no idea. And I'm like, 0.7 is good. And now I see here 0.9. So I hope it's really that fantastic, but that's something that I'm like, if I was studying this deeper, I would go and check like how did they evaluate this. But basically, let's believe the results, and we say that they demonstrate effectiveness and generalizability of AI-based bladder cancer classification. So that's good. Let's do another one, and then I'm going to show you a little surprise that we're going to get for everybody who's going to join at SITSI. Modernizing colorectal cancer care with artificial intelligence, real-time detection, radiomics, and digital pathology. So we have multimodality is entering the scene. Complexity increases, right? I'm just checking. I didn't check exactly like the impact factors, and I didn't do the affiliations. I'm going to do better next time so that you know exactly where these publications come from, and where the groups that are working on them come from as well. Okay, so AI is reshaping the colorectal cancer pathway. That's an interesting statement. Pathway to me, it's always like biological pathway. But it is boosting lesion detection and expediting molecular triage and enabling quantitative multimodal decision support. And evidence shows that computer-aided detection increases adenoma detection and lowers miss rate. I think we already covered, or there is a podcast episode on the AI-supported or AI-aided detection of polyps in colonoscopy, and how it can contribute to de-skilling of pathologists. That was like a discussion. We had a pretty cool discussion in the chat when we were discussing that paper. So whenever this live stream is published, I'm going to link to it, or I'm going to link to it in the show notes. But, when you take the AI away, people get worse when they detect this colorectal, the polyps. But with AI, they're better. So let's hope AI works and they can keep being better to help patients. Also, digital pathology can infer microsatellite instability from routine H&E slides, prioritize confirmatory testing. So this is the molecular testing, molecular prediction from H&E, a big thing, and then you just do confirmatory testing. And also we have CT and MRI, so we have radiology segmentation, radiomics-based risk stratification, nodal staging, and response prediction. And then we also have blood and genomics-driven models, and that extend non-invasive screening and prognosis. A bunch happening in colorectal cancer that is not just digital pathology, and we are using a lot of data, so we need high quality data, we need external validation, we need interpretability, workflow integration, and robust governance. So not really rocket science here as well, that we need all these things to deploy AI. something that I'm thinking, okay, this external validation, do you really need it if you're deploying it in just one institution? Maybe not. If you want to have a tool that is a tool that you can commercialize, definitely yes. And all the other things, interpretability, workflow integration, of course. So, but if we would want to have a deployable tool, we would need multi-center prospective studies, life cycle performance monitoring. I'm gonna do a exclamation mark here. I mentioned this life cycle performance monitoring last time when I was talking that I had Andrew Janowick and on a podcast. This podcast is going to be dropping hopefully within a few weeks about tool deployment, digital pathology tool deployment. And that's something that needs to be incorporated into every AI deployment, and not because the AI tool is going to be changing. The AI tool, once we lock it, is going to be locked until we make a new version, and then we will have to lock the new version as well. But what's going to be happening is the underlying biology is going to be changing. So me coming from the toxicologic pathology space, we have this database of different findings for animals. It's called historical control data. So we have a bunch of control animals where we record all the findings and we can access this data. But generally, the cutoff for usability of this data is 5 years because the animal's biology changes. So we always want to have the most recent 5 years of data of these animals, right? So the same happens with biology of people, of everybody, right? Sometimes, I mean, bacterial biology changes a lot faster than human biology, but it happens, right? Cancer biology, resistance to treatment, whatever. So this can happen, and you can start seeing a drop in performance of your tool, even though the tool stayed the same. So this performance monitoring is an important thing that I see coming up over and over again. And we have a comment from Patty. Sometimes the technical scientific part of implementation AI in these workflows is the easy part. And indeed, that is the case. So when I was talking to Andrew last time, he said that the creation of the tool itself took them maybe 3 weeks. So the tool was for detecting Helicobacter pylori, so bacteria in the stomach. Pretty easy from the computer vision standpoint, from the biology standpoint, also like easy visually for the pathologist. So it took them like 3 weeks to make the tool and 3 years to deploy the tool across the institution. So totally, like, you know, we think the difficult part is creating these algorithms, but no, the difficult part, well, the whole thing is kind of not that straightforward. Moving on to our next. Okay, after next one, I'm going to tell you about the surprise at SITC. Now, artificial intelligence, and we're doing across organs today. What did we have? We had the colorectal cancer, we had urothelial cancer, so every kind of organ-specific AI model we can think of. And now we have glomerular nephritis. So we are in the kidney using pathological image analysis approach and multi-center model development and validation study. Check something. Did I have a dot somewhere to tell you about? No, I just wanted to highlight the life cycle monitoring. All good. Multi-center, right? So complexity increases. The better we are, the more complicated we make the things as well. So the diagnosis of glomerular nephritis is based on kidney biopsy analysis by nephropathologists. And obviously, as any human assessment, it's going to be subjective, labor intensive, and will include inter-observer variability. We will not get rid of it. Doesn't matter how well you train the people to be aligned. If you have, 3 pathologists, if the 3 agree, it's like very, very high agreement. Usually we don't agree more than 0.7% when you look at these papers. But so what are we talking about? We are talking about AI-assisted model for diagnosing glomerular nephritis using histological images from kidney biopsies. And this was a model development and validation study and included patients who underwent kidney biopsy, right? And there were 4 different types of this glomerular nephritis: focal segmental glomerulosclerosis, IgA nephropathy, membranous nephropathy, and minimal change disease. I love this name, minimal change disease. There's minimal change, but it's disease. And obviously, I'm just making fun of it, but these are like official entities that have diagnostic features that the nephropathologists are very familiar with and can train a model on, right? So this was a study from China. There were 3 institutions. And again, we have a bunch of slides there. Jinyu, and Hawaiian. And I'm just on Duolingo. I am learning Chinese, but I'm only score Chinese 10, which if you are familiar with Duolingo scores, then you know. And if you are not, then it's very beginner. So apologies for my mispronunciation of Chinese city names. But the point here is that they had a lot of slides, and they're going to tell us how many. But they had a training cohort from one of the hospitals, internal validation cohort, 20% of these slides. And then they had two external validation cohort. And patients with diagnosis of one of the 4 specified glomerulonephritis types were included. So whenever one of these types was there, they were in the study. And the exclusion criterion was low quality biopsy images. So if we were doing like the full paper, I would go there, were like how low quality biopsy images were there? Were they not enough quality for the algorithm, or were they also not enough quality for human evaluation? That would be very sad, because then you have to take another biopsy and it's not fun. But they had over 100,000 glomeruli light microscopy images to develop this AI assisted diagnostic model. And AI had these 3 components. So they first glomerular localization module for segmenting glomeruli. So they go to a model recognizes glomeruli in the kidney, and then we have feature extraction and fusion model for glomerular lesion. And then we have patient level classification module to diagnose 4 types. So all of these glomerular nephritis that we just mentioned. And then they evaluated the F1 score precision, recall, and accuracy. And again, like our F1 score was F1 score of 85%. So it's the same as 0.85, right? But to me, this is like freaking high F1 score. Like really, precision 83 and recall 88. And what did they say about this? They say that by automating pathological diagnosing, the model may potentially be used to reduce clinician workload and improve efficiency, ultimately supporting faster diagnosis. And obviously, if you're a pathologist and you hear this supporting faster diagnosis, you always have mixed feelings about this, because I'm like, oh, am I now supposed to like read twice as many slides in the same time if I have this support? And there are mixed opinions on that, but the fact is, if you do have support, you probably are gonna be faster. And I'm like curious, automating pathological diagnosis, that's also like something that triggers, are you gonna now like not need pathologists? And things of that sort are kind of happening. So at ACVP and the American College of Veterinary Pathologists annual meeting, there was a mention of it's for animal diagnostics for cytology. Just one application of cytology. There was a mention that there is an option to get just AI generated results from the cytology, right? So the veterinarian can submit a sample and get an AI generated result within minutes, and only with additional payment and like additional effort will they get pathologist interpretation. So what's going on now in the pathology world? Well, you will see. I'm going to be following this. It was just a poster at the conference, so I'm going to be looking out for the publication. Once they publish, I'm going to bring it in here and we can dismantle this publication and see, and you can react to what do you think about this approach. And obviously it triggers me a little bit as a pathologist, especially veterinary pathologist, but let's figure out how we can stay in the loop so that it doesn't go wild and crazy. And before we move on to liver publication, let me show you the surprise that we're gonna have. They're gonna be stickers, but not these stickers. So I brought these guys. These are the Trailblazer stickers that I have for my Trailblazers. And you know what? I didn't even know, but they are dishwasher proof. I already put it on some of my cups. And actually, so if you have gotten one of these from me at the conference and didn't stick it anywhere yet, that's like so crooked. That's okay. They are dishwasher proof. So we're gonna make special ones for those who love immunofluorescence. And let me show you how they will look, because I have them prepared for you. My team already prepared mock-ups. Okay, here we're gonna have the brain Trailblazer. I don't know, so I'm not yet sure which one it's gonna be, if we're gonna have all of them. You can vote which one you like. Let's do 1 for brain, 2 for this trailblazer, the one with the background, and 3 for this one. Give me a 1, 2, 3 in the so these are the Hamamatsu now has this new device. It's called Moxiplex it's a fluorescent scanner for a lot of markers. I think in this one we have 9 markers. So the Hamamatsu team wanted to highlight this one where we have all the 9 colors. I also love this brain section because it's just so cool, and I like this design. So let me know in the comments which one you prefer, and maybe you can influence the decision which one we're going to print. And then when you come to our booth, the booth number 415, you can get one. And I'm going to make sure that they're going to be dishwasher proof and that you can put them on your bottle or on your mug or wherever you want to put them on. And that's going to be our gift for you with these beautiful immunofluorescence marker. And definitely if you come to this event that they're organizing with Dr. Bifulco, I'm going to have them there for you. So everybody who goes there is going to get a sticker. I'm like, yeah, teenagers put stickers on, but not anymore. 41-year-olds, almost 41-year-olds put stickers on their stuff as well. And I'm referring to myself. Look at this. Or maybe we're going to have more. Now, going back to our publications, liver. And I have tiny ones as well. I put them on my headphones, on my iPhone headphones, which I don't have an iPhone, but I have the iPhone headphones because I never know which box is mine and which is my husband's. And I put a normal one, like not a vinyl one, not this like special dishwasher proof on it. And after a few days of having it in my pocket, it got destroyed. So this one doesn't get destroyed, and it's a special size for earphones, headphones. Okay, I'm waiting for the numbers 1 to 3. And in the meantime, let's talk about AI for predictive diagnostics, prognosis, and decision support in MASLD, hepatocellular carcinoma, and digital pathology. So again, we're doing multimodality because it's and digital pathology. And what is our MASLD? This is metabolic dysfunction associated steatotic liver disease. You probably like pronounce it MASLD or something. Anyway, this metabolic dysfunction steatotic liver disease. And what's happening there? AI has been integrated into large-scale consortia such as Nimble, Litmus, Target NASH, Statosite. So a bunch of different efforts happening to incorporate AI to improve diagnostic accuracy and patient management. And the consortia utilize AI to derive and validate non-invasive biomarker in fibrosis staging. So why do we want non-invasive biomarkers? Because to do the fibrosis staging, so a non-invasive biomarker, right? How do you stage fibrosis? You need to take a biopsy, and taking a biopsy is invasive. We want to avoid invasive. So is there anything we can do that is non-invasive for establishing this? So also there's AI-based models to enhance the detection of hepatocyte ballooning, metabolic dysfunction associated steatohepatitis, minimizing inter-observer variability. You know what? Whenever there is an observer, aka pathologist, or radiologist, whoever, there is variability. And we want this to improve clinical trial enrollment criteria. And also there are AI applications to differentiate MASLD from alcohol-associated liver disease, and they use gut microbiome and metabolic profiling. So this is so cool because histologically they look super similar, but you can have this type of change in people who don't even drink, and it's very much metabolic associated. And then you profile the gut microbiome. Interesting. I need to learn more about that. In hepatocellular carcinoma, the AI improves risk stratification, diagnosis, and prognostication. And there's also AI-based models on liver stiffness and clinical parameters to stratify patients for a hepatocellular carcinoma development. And enhanced imaging techniques, radiomics, and histopathology powered by AI improve the accuracy of detecting indeterminate liver nodules, predicting microvascular invasion. And then AI also improves treatment response prediction for therapies such as this is called transarterial chemoembolization. I was not aware of this technique, and I guess if you don't have liver cancer, or are not a liver researcher or something, you don't know about it, but it's something like you can go through an artery and give chemo directly to the tumor and then embolize it, and meaning cut off the blood supply to the tumor. And this is used for tumors that are not, you cannot do surgery on them. So that was pretty interesting that you can use AI for that. And also for immune checkpoint inhibitors. So immune checkpoints, immune oncology, that's going to be covered at SITC for sure. So what do we have in digital pathology for this liver disease? AI has redefined fibrosis staging, donor liver steatosis assessment. This is super important, and disease diagnosis. So donor steatosis assessment. This is something happening when people donate livers, and often that happens when people are in a coma, about to die, and you take a biopsy and you assess it. If it's good, then you can transplant. If it's not good, you cannot, right? And we have some exceptional platforms, Fibronest, and why am I like talking about it with a kind of different voice? Because I have personal experience with this type of stuff. That's how I know. Anyway, platforms. Fibronest and Q Fibrosis are two exceptional AA platforms, and we are happy because the field of MASLD, HCC, hepatocellular carcinoma, and digital pathology is advancing toward precision medicine. And I want to tell you about a conversation I had at some point. It was maybe 2 years ago or 3 years ago. I was talking to someone who was doing this type of liver research, and they were asking me, like, how can we do more non-invasive? How can we get rid of this requirement of needing to do a biopsy to assign somebody to a clinical trial? I actually don't know if this has already happened, but at that point, 3 years ago, I'm like, oh, I don't know how you're gonna get this through the FDA and change these guidelines, because it's such a Herculean effort to do this. But people do it. People like publish, update guidelines. They are not set in stone. So if you are part of this type of research, definitely effort worth publishing. And publishing to deployment, there's a lot of ground that needs to be covered, but publishing is the first step, right? There's so much more happening before publishing. So if you already publish, it's out there, can be cited. And I remember that conversation and I was like, oh my goodness, how are you going to do this? It's probably doable. It was just like the beginning of these vision models, transformers, and multimodality in pathology. And I'm like, yeah, you could probably label your ultrasound or whatever with exact corresponding histopathology images, and you have like direct labels. We are basically discussing how we would approach this type of study. I don't know what happened. Maybe I'll hear from this researcher after this episode. One more thing, the lightweight supervised learning framework for domain generalization in histopathology. Yeah, so I told you at the beginning that at ACVP there was domain generalization discussion, and there's always somebody. So domain shift is when you have a model, and let's do the histopathology or pathology example, right? We need digital images for this. We need digital slides, right? So if you develop a model on digital slides from one scanner and then you change the scanner, you kind of shift the domain, and your model does not perform that well on this new slide. And there's always one person who says, like, what do you mean it's not going to perform? I see a glomerulus here, and I see a glomerulus here. Inflammation here, it looks the same as inflammation here. And then he like went on to saying, oh, inflammation in human is the same as inflammation in mouse or in dog and whatever. Yes, it is. But for you as a human observer, and you're not a computer that reacts to every single variation in domain, including, staining, thickness of section, and these slide scanners, right? We are pretty good. Even though we have such huge inter-observer variability, we are gonna recognize these glomeruli in many different shapes and forms. So anyway, there's always this discussion, like, how come this domain shift influences so much, and how come you have to test this always if it looks the same? Well, it doesn't look the same. That's why we need to test. And the question is here, okay, is lightweight self-supervised learning framework going to be good for domain generalization. There is a surprise in this abstract. I was smiling when I realized this surprise. So, large foundation models in histopathology. Foundation models are basically huge models, big models that can do a lot instead of just like very specific one that detects glomeruli, right? So we have these foundation models for histopathology, and they have demonstrated significant potential in advancing computational pathology very much. Now, basically you can potentially remove the bottleneck of annotations or reduce it so much. You have like companies that are hiring pathologists to make annotations for these type of projects. I get like inquiries on LinkedIn. Oh, $50 an hour for annotations, and you need to have an MD and the best, or DVM or PhD. I'm like, yeah, no, my job is okay. I don't need to do additional annotating jobs, but that was what was required and what still is required to have good performing models, right? So those foundation models have the potential to overcome the domain gap between training and testing data sets. So domain gap can be like anything, different scanners, different labs, different stains, different whatevers, right? We don't even probably know. Like, it's a little bit like magic. And any of my computer scientists, please comment on domain, on the domain shift, because when I hear like what kind of domain variability sources can there be, I'm like, this is a little bit like IHC magic. Domain shift magic is another magic domain in this digital pathology space. Anyway, however, but they are huge, right? So they rely on vast computational resources, and that often limits accessibility and widespread adoption of foundation models. And now we have this HistoLite, a lightweight self-supervised learning framework designed to enable domain-invariant representation learning in histopathology. This domain discussion is like, okay, if you know that you're going to have slides from different places and images from different places, you want to make a model generalizable. So you want to make it kind of like immune or resistant to domain shift. So you want to include as many domains in development as possible. And that's what happened for these foundation models, right? But we are now having this light model, HistoLite. HistoLite utilizes customizable autoencoders within self-supervised learning paradigm that learns generalized and transferable features in an efficient manner. We evaluated the proposed framework using breast whole slide images and benchmarked performance with state-of-art foundation models for domain generalization. And we're going to learn which these foundation models are in pathology. So they had a novel data set that was same tissue slides scanned by two different scanning platforms. So here we're focusing very much on the scanner domain shift, and they did analysis of covariate shifts due to scanner bias. They evaluated, for example, differences in embeddings across scanners. And the top models that they used was Virco2 Prof GigaPath. These are like kind of famous if you look at the foundation model literature. And did we cover? I think we did cover Uni or Virco 1 maybe in one of our DigiPath Digests. So these are like the ones that are gonna pop up. And in general, most foundation models were found to be susceptible to scanner bias, and as shown by differences in embeddings and drop in performance on the held out scanner, so the one that the stuff was not scanned on. HistoLite offer low representation shift in embeddings. Yay! Lowest performance drop on out-of-domain data with modest classification accuracy. So that's the surprise. I'm like, okay, it was fantastic for domain shift, but it was not accurate anymore. So I don't think they solved the problem, but it indicated that the smaller model may exhibit a trade-off between accuracy and generalization. So, okay, that's what happens. They made a smaller one, but it was less accurate. And again, these are all the nuances. It then like enters into the kind of like philosophical discussions on different things. But next weekend, SITSI near DC, National Harbor. Let me know. Do you want number 1? Do you want number 2? Do you want number 3? And if you're not going to SITSI, that's okay. You can vote for the sticker as well, because maybe at some other conference I will still have them, or Hamamatsu will have them, and also maybe BioCare will have them, because BioCare is another partner that is going to be co-sponsoring this coverage of SITC for them. Also, what we would like to do, if you are at SITC, then join for the From Spatial Biology to Clinical Utility. We are not going to be streaming this one. There are going to be live streams from the Hamamatsu booth during SITC, and I think one from the BioCare booth, or just come to the booth. You can visit me and see me live streaming if you want. Although maybe we're going to do it before the exhibit hall opens. We'll see. But if there is a chance for you to just see me live stream, you can do that. So if you can join. And that would be fantastic to see you there in person. And I wish you happy Halloween. Have fun. If you like dressing up, dress up. I'm like, this is the most I like to dress up, and how you see me at conferences. I didn't really grow up doing Halloween because I grew up in Poland and it was not a thing. Now it's a bigger thing. But still, I think there are mixed feelings about this. But here, US, obviously, my kids are already getting ready to put costumes on. I prepared this year. I was not sitting till midnight yesterday making costumes. Here, pumpkin. Let me know which one you prefer. And also, Trailblazers. If you didn't get the book, so what happened is I started sending messages on LinkedIn and asking people if they know that there is a book. And you know how many people say they don't know there is a book? So if you don't know there is a book called Digital Pathology 101, especially if you're at the beginning of your digital pathology journey, or if you have like expertise in one domain. So when I was starting, I came from the image analysis side of digital pathology. So that was like my kind of kernel of expertise. And then I had to learn everything around. And then I wrote this book so that you can have this not too long. It's going to be updated. The QR code is for you to download the PDF for free. And if you have the PDF for free, you will be on my email list. That means whenever the new version comes out, which did not come out yet, although I wanted to do it last month, but it will come out before the end of the year, you will automatically get it. So, let's eliminate decision fatigue, get the code, get the book, and you're gonna get the new version as well. And obviously, if we're interested in getting these for yourself, meaning the earrings that I wear for the conferences, my kind of signature earrings, so if you wanna give them to somebody for Thanksgiving or maybe for Christmas already, if you are so well prepared that you're already thinking about Christmas, you can do that in the store. There is a QR code in the other corner. And anything else, if you're up for a course, there is an AI in pathology course, Pathology AI Makeover, now in the corner. But actually you can get to this course through the store, so just go to the store, check it out. And if you don't want to go to the store, the book is something that's gonna make your digital pathology life easier. Thank you so much for staying till the end. It means you are a real trailblazer, and I hope to see you at SITC at the Hamamatsu booth 415. Talk to you in the next episode.